Good afternoon, ladies and gentlemen. I'm very happy to here to talk about clinical pathway on diagnosis and treatment of HFpEF. I come from Guangdong Provincial People's Hospital. And we know there are about 64 million people have heart failure. HFpEF accounts from 19% to 55% in the last year. And in China, there are about 89 million people with heart failure. And we know last year, our study showed that compared to patients from the United States or Europe, Chinese patients of the HFpEF patients had poor outcomes. The higher rate of heart failure, heart failure hospitalization and cardiovascular death. This is our study in last year. We have published in European General Heart Failure Journal. And among HFpEF patients, women generally had poorer outcomes at 1 year follow-up than men across the 3 LVEF groups. This article was accepted by European Heart Journal yesterday. We have received the email. And we also say how to diagnose HFpEF. In the new ESC guideline, we know if we should be diagnosis HFpEF should be based on clinical symptoms, signs, left ventricle ejection fraction, and biomarkers such as anti-proBNP level and the echo changes of diastolic dysfunction or raised left ventricle filling pressure, including raised anti-proBNP or BNP levels. So if we have this diagnosis, we also talk about how about the pathologies of HFpEF. There are 3 major pathways lead to HFpEF: hypertension, heart disease, and we see during the patients with hypertensive heart disease, pulmonary vascular right ventricular and right artery remodeling and dysfunction. The second with the myocardial vascular inflammation. And with these patients, we also found a pulmonary hypertension with pulmonary vascular and right ventricular and right artery remodeling and dysfunction. The third and another complex pathways. Sometimes we diverse HFpEF phenotypes just plus these 3 types. And in China, Professor Ge Junbo has introduced 5 HFpEF phenotypes in Chinese patients, just according to clinical disease. That is vascular related and cardiomyopathy related, right heart and pulmonary related, valvular and rhythm related, and extracardiac disease related. In the first type, we know the brief description that with hypertension, CAD, and coronary myocardial vascular dysfunction related HFpEF. And in second phenotype, these patients may have hypertrophic cardiomyopathy, inflammation cardiomyopathies like cardiomyloidosis and fibroid cardiomyopathy, which induced the HFpEF. And the third phenotype, patients in the subtype often have pulmonary hypertension with or without right ventricular dysfunction. And the fourth, valvular and rhythm-related HFpEF, it mainly refers to HFpEF resulting from valvular disease and atrial fibrillation. And in the fifth phenotype, extra disease involved metabolic disease such as diabetes, obesity, and metabolic syndrome. Diseases that often cause high outcome states such as anemia, liver disease, hypothyroidism, and arteriovenous fistulas. Other diseases such as CKD and radiotherapy for cancer and so on. How to diagnose HFpEF? First, we should confirm heart failure, including history and physical examination, echo, and raised biomarkers such as anti-proBNP and all BNP level. Second, we should confirm heart failure phenotype based on left ventricular ejection fraction measurement. And very important, we should determine etiology. This is very important in clinical. We met patients, we should diagnose HFpEF. And the H2FPEF score including body weight, hypertension, arterial fibrillation, pulmonary hypertension, age, and the left ventricular filling pressure. The scores, we can calculate it from 0 to 9, and the score between 6 to 9, we should highly probability the patient will be diagnosed HFpEF. How to treatment HFpEF? We know treatment for HFpEF includes SGLT2 inhibitors, diuretics, and other disease therapy according to the new ESC focuses update of the ESC guidelines. But we know in the past, previous randomized clinical trials did not find benefit with ARB, ACE inhibitors, and MRA of HFpEF treatment. We know in CHAM-preserved and in IPRES clinical trial that ARB cannot do the benefit for HFpEF. And in PEP chronic heart failure trial, ACE inhibitor predopia cannot get the benefit for HFpEF patients. And in TOPCAP clinical trial, MRA also cannot do benefits for HFpEF patients. So how about the new medicine of ANI? In Paragon heart failure trial indicates that HFpEF patients with some no LVEF and 60% may have benefits from ANI treatment, just like those patients in Paradigm heart failure. Now, we have another new medicine to treat HFpEF. In Emperor preserved trial, we have no EMPA, the SGLT2 inhibitor, one of SGLT2 inhibitor can reduce cardiovascular death and heart failure hospitalization in HFpEF patients. So we also can see the include patients, their LVEF above 40%. So these patients maybe have some with the heart failure mild reduced. And in DELIVER trial, we also see DAPA can reduce worsening heart failure and cardiovascular death in HFpEF patients. In this clinical trial, we also think these patients ignore that their LVEF above 40%. So there are some mild reduced EF patients in this clinical trial, but prospective subgroups based on left ventricle ejection fraction show benefits in patients with LVEF above 50%. So in nowadays, we treat HFpEF patients with ACE inhibitor, ARB, ARNI, or MRA or beta blockers. But there are no routine use in HFpEF, but indicated for hypertension, CKD, and with no net benefits for HFpEF in parallel randomized clinical trials, but still useful in blood pressure control and renal protection, use these medicines. How about with treatment for comorbidities? We also should treat other disease such as coronary artery disease, hypertension, amyloidosis, valvular disease, arrhythmia, and extra cardiac disease. And we also use diuretics to these HFpEF patients. And in the new ES guideline, SGLT2 inhibitors are recommended to these patients. And we should know we should management another disease of HFpEF. We should primary studies showed that ATTR amyloidosis is common in HFpEF patients, and we should consider this disease when treating HFpEF. But we should distinguish ATTR-CM from immunoglobulin light chain disease. This is very important for the patients. And other management for HFpEF patients, we should treat ulcer and obesity, and also tell patients to do exercise, smoking cessation, and alcohol control. This is very important to the patients to give them educations. And now in this year, ESC Congress, a new study, STEP HFpEF study trial, suggests that GLP-1 receptor agonist semaglutide might be useful in improving symptoms in patients with obesity, including KCCQ, CSS, and lost body weight in primary endpoint, and increase 6-minute walk distance in secondary endpoint. Maybe this will the future medicine in clinical treatment of HFpEF. So in the last take home messages, the first, we have three essential diagnosis elements, including symptoms and signs of heart failure, left ventricular ejection fraction above 50%, evidence of left ventricular dysfunction used with ankle or nested peptides. Second, two recommended medicine catalogs, including SGLT2 inhibitors, DAPA and empagliflozin, and diuretics in overload. The third, treatments of etiology and comorbidities. This asks doctors to screen for ATTR or other causes can make the patients of HFpEF. Thank you very much.